Okay, I think Facebook Live is not going to work for us anyway. It's been so tricky. So I'm just going to record it to my computer. I'm going to go ahead and share my screen here, and we'll get started. Mm, Okay, so hopefully everyone can see that.
Okay.
Okay.
I stopped sharing.
Oh, great. Okay, hello everyone. Good afternoon, and welcome to our first webinar in our Breast Cancer Awareness Month webinar series. Today, our presenter will be talking about using artificial intelligence in breast cancer screening. Just a couple of housekeeping notes here. Please remain on mute while you're not speaking so that we can cut down on any background noise. This webinar will not be streamed to Facebook Live, but it will be uploaded later to our YouTube. And as we go through the presentation, please use the chat box to ask any questions for our speaker today. You can just type your questions right into the chat box, or if you'd like to ask a question anonymously, you can find my name. So my name is Aliapoulos. Here it is. It should say host next to it on the Zoom, so that should tell you that that's me. And you can ask a question directly to me, and I can ask it on your behalf to our speaker today. So, as I mentioned, my name is Lilia, and I'm an education outreach specialist in the Office of Community Engagement and Cancer Health Equity at the University of Chicago Medicine Comprehensive Cancer Center. So, this here is a slide with our team members on it. We work with cancer researchers and clinicians at the University of Chicago and try to connect them with educational opportunities for the larger community, including within the university and outside of the university. So that's where programming like this fits into our work. And we are so thrilled today to welcome our speaker, Dr. Maryellen Geiger. She is the A.N. Pritzker Distinguished Service Professor of Radiology for the Committee on Medical Physics at the University of Chicago. And I'm going to stop sharing my screen and throw it to Dr. Geiger, who's going to speak with us today. Thank you so much again for being here today, Dr. Geiger, and welcome.
Thank you. And I'm very happy to be here today. Let me just get these up. Um, I look forward to this presentation and discussion. I know we have a very mixed audience, which is great because probably get a lot of good different viewpoints at the end. Um, and also, I'm going to keep this at a rather high level to cover a large portion and to get my comments and commentary out on it. So I'm going to focus on AI and CAD, computer-aided diagnosis, and breast cancer screening. These are my funding and conflicts of interest. Okay, so we know breast cancer screening saves lives. However, there's always room for improvement. There's difficulty with dense breasts. We want to find cancers earlier with fewer false alarms. In fact, the false alarms in breast cancer screening each year is about 700,000 women each year in the US get unnecessary biopsies. So we can look at here, this is a mammogram, back to back, left and right. Uh, there's a cancer hiding in there. It's difficult to see, um, and it's actually right there. Or we're in the situation where we have found a lesion, and I should note that I'm not a clinician, I'm a researcher, but there's an obvious lesion there, but is it cancer or benign? And that one is, in fact, benign. So detection and diagnosis are difficult tasks. However, they can be improved by newer medical imaging and novel AI. All that is powered by math, physics, engineering, technology, collaborating with clinicians. You need the whole multidisciplinary team. Finding and diagnosing tumors in dense breasts is a major problem affecting many people. Mammography is not perfect. However, there are other modalities, such as here using MRI, to see that tumor and to assess it. So that's giving you a feel what kind of images are being looked at. What do? I work on AI and medical imaging, looking to come up with new diagnostics, clinical endpoint. The focus here is AI for images that are clinically and routinely obtained in the population. We want to ask questions about the relationship between what is seen in the medical images by radiologists as well as by the computer, and the biology of cancer so that eventually we can detect, diagnose cancer early and give the right patient the right treatment at the right time. Now, AI can also be used for image reconstruction to improve the efficiency and the workflow of medical imaging, and as well as in biomarker discovery and diagnostics. We're not going to cover that part today. So my lab at the university has the goal to develop, validate, test, and translate AI for medical imaging, especially for breast cancer imaging, to improve patient care, diagnosis, treatment, and outcome. We want to, in a way, try to reveal what's invisible, though often it's not invisible, it's just not noticed, by combining imaging with AI. But what is AI? There's a lot of definitions. I take a very broad definition of AI. It's the theory and development of computer systems able to perform tasks that usually require human intelligence. It can learn from data, identify patterns, make decisions, and it includes all those various algorithms you might have heard about, foundation model, deep learning, machine learning, rule-based, all that is AI. And in fact, many of them have been and continue to be in computer-aided detection and computer-aided diagnosis systems, which were initially brought on in the 1980s and 90s. So let's look at how this would work. A patient undergoes imaging. The images are evaluated using an FDA-approved AI system for a specific clinical task and an intended population. The report is then given and generated using whatever is the output from the system. The AI system gives a prediction, and that is passed to the provider, the clinician, who uses it as an aid, as a tool, as another component in their overall decision making. So the computer might be giving a predictive aid, such as maybe the likelihood that the case has a lesion or a likelihood that the lesion is cancerous, and the radiologists and the other clinicians would use that in their assessment. Sometimes the computer could act as a primary reader or a partial primary reader, such as taking the cases and looking at them and bringing the most suspicious ones to the top of the reading order. So that gets attention very quickly. Or they can use it as rule out, whereas in breast cancer screening, where most cases are normal, if the computer could say these 20% are clearly normal, and then a patient could wait till the following year to get their screening mammogram without a radiologist reading it. So we're moving towards that part, partial primary. To create all these, you need representative data to yield trustworthy AI. You need to understand how the end user will use the AI output, and I'll get to that in a while. Recognize the responsibility of the AI system as well as the people who use the AI system, not to use it off label. And there's various bioethical considerations there. Now, for AI in medicine, medical imaging AI leads the way if you look at the FDA cleared algorithms. At FDA, these AI algorithms are seen as software as a medical device. And you see those coming from radiology account for over 75% of those algorithms. So AI in medical imaging has been around for much longer and has more presence at FDA, and we continue to evolve there. Let's look at what's important in AI, in development, testing, clinical use. So first, it's very important to know garbage in, garbage out. You need to know your input. Is it diverse, representative? Do you have correct truth on it? And you need to understand a problem of shortcuts. So if the device is FDA approved for one task, such as analysis of, say, breast MRI, and you put in an ultrasound and it doesn't work, it's because garbage in, garbage out. It was not approved for an ultrasound in it. It's very important to know how to develop AI algorithms. There's a lot of algorithms out there. And how do you put all those different algorithms and methods together for your specific clinical question and task? And this often involves multidisciplinary teams. I'm a medical physicist. I work with radiologists. I work with epidemiologists, biologists, cancer biologists, surgeons, and others. And here we can develop the algorithm for detection, risk assessment, diagnosis, prognosis, therapy response, and others. And then you need to know who is the end user and how will they use the AI output. There's responsibility of both here. For example, here, often AI is used as an aid. It's a secondary or concurrent reader. It's similar to when you have a blood test and you have a printout of all these various tests that were done and where your result sits within a range of normal. The physician then takes all those results and incorporates them into his or her decision making. Same thing here. The output from the computer is incorporated into the clinician's decision making. Now, I mentioned earlier as a primary reader, where that would be used for triage or rule out. And then autonomous AI, where you replace the human altogether, I think we're far from that still. So let's look at some history of AI in the detection of suspect lesions in screening mammograms. So this is from 1994. This was a prototype that was put here at the University of Chicago. This was the first AI system to aid in breast cancer detection. It looked for mass lesions and clustered microcalcifications. You can see it's quite large. Here on the left, we have the film digitizer. Back there, we still had film. Storage system, computer, printout of the results. And here's, you can see the timestamp. And here's an example. We have an arrow for focusing on a true positive. There's an actual lesion there. The other one's focusing on false positive. There is nothing there. And at the bottom, we have a false negative. There's not pointing out the lesion there. This this was then licensed by the university, incorporated into a system which underwent FDA approval in 1998. And I'm showing you the history because I think it's very important. Many of the concerns and evaluation methods back then are still held to today. So this led to the commercialization of it. And an interesting fact is that this algorithm, which in the system, which was published in 1994, included a deep network. It wasn't called convolutional, it wasn't called deep, but it was. It was called shift invariant artificial neural network. So a lot of this work has been going on for a long time. Of course, back then we realized that the performance needed to be improved. Radiologists needed to learn that AI systems should only be used for the tasks for which they were developed, not as a primary reader, if it was approved as a secondary. Sometimes the computer would output a false positive. You couldn't just go with that. And not off-label and not for other types of breast images. And there's been many publications. I'm not going to go through these here, but I mainly want to put this up to note to you that while mainly used as a complementary detection tool for the radiologists, many of you, if you get a screening mammogram, AI has been run on it for many, many years. You may not even know that, but it's there. But right now, AI in breast cancer screening is reaching potentially clinical levels as a primary reader, especially for rule out. AI for screening is being used on both digital mammography as well as digital breast tomosynthesis, aiming to improve sensitivity, specificity, as well as improve the workload efficiency for the radiologists. Now, there's still challenges. There's lack of standardized data sets because images come in from different institutions, different manufacturers, and other various attributes. There's a limited understanding of causes of bias, and I'll get to that later. And regulatory approval is intense and does take a while, but they have to make sure we get it right. Let's look at AI in diagnosis of breast cancer. So once a lesion is found, the patient then goes under workup to look at what is the likelihood that this lesion is cancerous. Could the computer help to characterize the tumor and potentially indicate a computer-determined probability of malignancy, leaving, of course, the final decision on patient management to the radiologist. So on the left, we have a benign. On the right, we have a clearly malignant case. The middle is kind of confusing. That is, in fact, a cancer. So in the interpretation for workup, the radiologist would be looking at mammograms, ultrasound, MRIs. This is Dr. Gillian Newstead, who used to work here as a mammographer. And she's spinning. She has to look at all these cases. And that's a lot of data to integrate to come up with what is the likelihood of cancer and what should be the patient management. So could a computer help there? Keep in mind at this stage, since the workup would include mammograms, ultrasound, MRI, the AI or computer-aided diagnosis could be applied to all those modalities. I'm going to focus today on MRI. So this is a clinical DCE, dynamic contrast enhanced breast MRI image. It's 3D and it's subtraction. And so that helps you see that lesion there. So the patient undergoes multiple imaging while contrast is injected and goes through the tumor. If you subtract the one with contrast from the one before contrast was injected, you'll get an image something like this. And so you can see this tumor right here. So we've developed a lot of AI for this. We worked on automatically segmenting the tumor. Think of it as a virtual biopsy of the tumor. And then we extracted lesion features, characteristics, or basically mathematical descriptors that were converted to software that characterize the lesion, such as size, shape, morphology, uptake of the contrast agent. These 3D, sometimes 4D features could then be merged by a classifier to yield a signature giving a likelihood malignancy or a likelihood of how aggressive the tumor is, depending on your training. So this was back in the late 90s, early 2000. Here's an example. This is a simple example where the shape of the breast tumor is important to the clinician working up the case. And what we can do is convert these lesion characteristics to mathematical descriptors called radiomics. On the left, we have the sphericity of a tumor. On the right, we have the irregularity. How irregular is that tumor? And these are calculated in 3D. However, we could also take a multitude of different features that we can extract and combine them into a more complex characteristic of the tumor. So here we have a DCE breast MRI image with a slice through the two breasts. Now, we want to relate the AI we're pulling out to the biology, and here we're interested in looking at the intra-tumor heterogeneity. Tumors have increased blood vessels and differ in microvascular density and vessel permeability. So we do MRI with contrast agent over time. And as we do that, each voxel, so this is 4D, it's 3D over time, each voxel could be looked at for uptake. Now this curve over here on the right, we see that cancers tend to have rapid uptake and wash out, where more benign type lesions are much slower in uptake. Not always, but often. And we can look at that uptake characteristic for each different voxel. So you see some places in the tumor have an uptake and a washout. Other places in the tumor have a very slow uptake. Now, we can do, just like we segmented the tumor, we can segment these different components in the tumor. We end up looking at different components. And here, these are the cross sections of the tumor. Remember, it's three-dimensional. The red voxels correspond to areas where there was that rapid uptake and washout. And we can look at the texture of those to give us a numeric value, a number that is related to the heterogeneity of the contrast uptake. And we have found this as a very useful feature in distinguishing between cancer and benign lesions. We can also look at the volume of those most enhancing voxels. And instead of looking at the volume of the tumor, only look at the volume of those very active, those vascular areas where there's rapid uptake and washout. And for that, we refer to as the most enhancing volume, which we have found to be useful in assessing the risk of occurrence. Now, besides those intuitive features that we've also looked at deep learning. And here in the roughly around 2015, we started looking at embeddings. Those are features extracted from a trained network. This basically transferred deep learning. There is no need to segment the lesion or pull out those intuitive features, but with it, we're still addressing the task of distinguishing between cancers and non-cancer. And because we were using transfer learning, it reduced the number of cases as opposed to learning from scratch, which would have required more. Now, we've done a lot of research with those, but with our limited time here, I just want to point out a few high-level concepts. One of the things we did was we took our methods, we worked with the University of Chicago Postkey Center, and we translated it to a university startup company, which was called Quantitative Insights, and the product was Quantex. This became the first FDA-cleared machine learning-driven system to aid in cancer diagnosis. Up until this time, there had been ones working on detection of lesions. Here, we were trying to then diagnose this. And basically, what we did was we took our prototype and converted it into a product. And then colleagues evaluated the performance of it. And while it's important to know how good is the computer, what you're really interested in is how good is the radiologist versus how good is that radiologist when they're using this computer aid, this AI assistance. And what we found is all of them improved when they used this, and that helped to get the FDA approval. We were named as one of the best inventions in 2019 in Time Magazine, and we went on to put this in a few clinical areas, and then Quantex was bought. But what I want to point out is another big part of why getting this FDA approved was so important. At that time, this category for assessing the likelihood of malignancy did not exist yet. So it was called a de novo, refers to a FDA pathway for novel medical devices where there's not a similar device out there. However, when we got approval, this enabled other to get approvals because they used us as a predicate. And so this was kind of like a side effect of what we were going after. And this helped other groups in breast cancer, as well as in coronary artery disease, prostate cancer, lung nodule, and others use and build on this category. And this is important to get AI developments out to the clinical as soon as possible in a careful way. Let's get back to, I think I'm going faster than I planned, other parts of what we've worked on. So understanding cancer is not just imaging, is not just biopsy, it's multiple. So what we were interested in is looking at the medical image, working through our computer vision algorithms to do a quantitative assessment, and look how these associated with the clinical or biological questions and develop predictive models. And we wanted to ask of our imaging characteristics, our histopathology molecular classification, and the genomics, which ones are correlated and which ones are synergistic. And we've worked as a big multidisciplinary team from across the US with University of Chicago playing a major role. We looked at multiple ways to relate our features that we pulled from the dynamic contrast enhanced breast images to different other markers. Here, this is showing a comparison of our what we've pulled from the image, features related to tumor shape, tumor size, tumor heterogeneity, and related to various cancer pathways. Now, this was using data from the NCI, TCGA, and TCIA data sets that enabled us to do this pilot study. We're now working between departments of radiology and medicine in the oncology area to take this further with a larger data set. But this is very promising. We found that transcriptional activities of various genetic pathways were positively associated with tumor size, blurred tumor margin, and irregular tumor shape, and that microRNA expressions were associated with tumor radiomic phenotypes of size and enhancement texture, suggesting that microRNAs may mediate the growth of tumor and the heterogeneity of angiogenesis in the tumor. That is, in that increase in vasculature in the tumor, but having it very heterogeneous in the tumor. Now, other work is going on. We can improve the breast cancer detection and diagnosis by looking at new imaging systems as well as in new AI methods. And let's look at an example. So here, how can we take the screening mammogram and make it smarter? Could we save more lives with fewer false alarms? And this is a work that's going on. It's an NIH NCI funded grant between the University of Hawaii Cancer Center, Moffitt Cancer Center, and the University of Chicago. It's called 3CB for three compartmental breast imaging for improved cancer diagnosis. It works using a step wedge and dual energy, and it first is calibrated with the phantom. Based on that, we can solve equations to measure water, lipid, and protein content of the image. And this would be done, we're doing it at the diagnostic stage, but you could see where this could go, and hopefully that's a later step for us to use it at screening. Basically, here's the screening mammogram. And from this, there's the blow up of the tumor. If this was taken with the 3CB method, which only is a little bit more dose, we can then use calculations to pull out the water content, the lipid, and the protein. Here, red means higher content. So the water content is high on this tumor. Likelihood this is a cancer, because why does it have high water content? The cancers have more cells, which have more water, and the cancer create more vessels, which have water. And this is actually a cancer. Here's another example of 3CB imaging. Here, there's the tumor down there. And here its distribution for water, lipid, and protein. You see the outline of the tumor here, here, and here. This one has low water, high lipid, and low protein. So probably benign. Now, as we develop more and more AI, we need to make sure we have lots of data that's representative. So there's a huge need now for curated, representative, diverse, and reusable data. Once the patient has had their mammogram, it served its purpose, and it will continue to be used clinically. However, could it be used to improve the next generation of imaging and AI? And we've done this, launched in August of 2020. This is an NIH initiative through the NIBIB Institute. We have been collecting data. We don't have breast cancer data on this yet, but we will. We've ingested over 500,000 imaging studies, mainly chest radiographs and chest CTs. We have two components. One is where we ingest the images in our centralized data commons. And this is important. So, and we have it open. This is all de-identified so that everyone, we we even out the playing field so everyone can develop the AI. We also have a distributed federated method where we index other commons out there to help an investigator find data. To me, data takes in research, data accounts for, and prepping the data accounts for about 80% of the effort. So through collecting and sharing data, MIDRC is helping in the development of AI for diagnosis and treatment of cancer and other diseases and conditions. The other big part of MIDRC is we have many open resources, tools, and algorithms to help the people developing AI. Some are web-based, some are downloadable, and all of you can go to midric.org. All this is open. You can check it out, email me if you have questions. I will bring up one tool, we have many there. One is the MIDRC AI reliability tool. And this is very important because sometimes people develop algorithms without realizing that their data may be biased. For example, their data all comes from one institution and then it's going to just be used in another institution. The populations are different. The type of acquisition system may be different. So this helps one in learning how to find different sources of bias. And I'll show you. And if you want to, this is open, you can pull it down off the website and run through it yourself. But it will come up. It will list all sorts of types of bias. And here, if we choose population bias, it will tell us what it is, why it occurs, why it is important, and how it is measured. And then it will summarize it. And it being aware of potential bias when you have an AI algorithm, whether you're the developer or the user, it's crucial to understand that. So in summary, we've talked about how a patient might have an FDA AI system um, uh, used on their imaging, reporting it to the clinician who uses it in their overall decision making. We understand that the data has to be representative to yield trustworthy systems, and we have to understand how the end user will use it. So any input, I'm always open. Come talk with us. We aim to continue to develop, validate, and test and translate AI for medical imaging to improve patient care, diagnosis, treatment, and outcome. We look at imaging methods, AI methods to improve outcome. None of this is possible by just me. I have an awesome lab, uh, outstanding folks in research. We've been together over 20 years and fantastic graduate students in medical physics. There are currently 3 in the lab. And of course, MIDRC and all the support we get with them. Thank you, and I can take questions now. I'm a little faster than I thought. Sorry about that. Could have put more in.
Oh, no worries. Thank you so much, Dr. Geiger. That was a really great overview um, of your work here. And just as an FYI, I did put the Midrick website into the chat box for anybody who wants to check that out. So
Okay.
I have a few questions that came in, and I've just been jotting them down here. So you talked a lot about how this is used in breast cancer screening, and I think you sort of alluded to this. How easily replicated is it across other cancer sites?
Yes, and that's what when in the early days, we didn't have many cases. So of course we would develop it. We would try to get cases from different institutions. People write papers. Often they're called single site papers. They're not very generalizable. Then now with more and more data, people are moving to where they develop with data from multiple sites and then test it on other sites that were not included. That's a route you have to go if you want to go through FDA, and you have to go through FDA to get into clinical practice. Um, this is a major aspect of developing AI and testing AI. And this is what drove us to create Midric, because people do not have access. And so 80% of what we bring into Midrick, we share openly to everyone. Any researcher can go and download and use it. We do keep 20% on the side and a secret and a sequestered um, data so that we can ultimately work with AI developers to safely test their algorithms as they go through FDA. Many of us have taken algorithms through FDA, so we know the steps that are needed. Um, and I can't overstate how important the data itself is. I mentioned in my talk the word shortcut. I thought I would be too long, so I took out that slide. Basically, you may have a system that does really well in distinguishing between the positive and negative abnormality, say cancer versus benign. And it works really well. And then when you apply it elsewhere, it still works well. But then when you apply it on a third site, it doesn't work. And maybe what was happening is site 1 and 2 had the same manufacturer for the mammography system, and site 3 didn't. And so the shortcut implies my AI is giving a high performance value because of the differences between uh, the cases based on how they were acquired or how the protocol was done at the different sites, as opposed to differences in the medical part and the biology part of the tumor. And one has to be very careful of this. And that comes from knowing your data. I'll tell you an interesting story way back when people were trying to develop AI to determine if chest radiographs had a pneumothorax in them. And they pulled their chest radiographs with pneumothoraces from an ICU. And then they went to their pot of normals and pulled those without. And they were getting very high performance levels, but it wasn't real. What they were really detecting were the tubes and the wires in the chest in the ICU. That's a shortcut, and you want to avoid those.
Thank you for that explanation. So I have a question here. Speaking of data, and I don't know if this is something that's answerable, but it's kind of an interesting question. Um, how do you, and for lack of a better word, donate your imaging to these large scale data sets? Like, how could a person who's, a
Mhm,
patient just going in is like, yes, I want to be part of clinical research.
mhm.
I want to use, my imaging for the betterment of this tool. Like, is there a way for people to do that?
A great question. So the way we view images is that the images were first done for the patient, and that was accomplished. The images then benefited the institution because they got reimbursed for it. It then that goes on a shelf. Put that image to good work for a secondary usage of it. Now we have about 14 institutions who have donated data, de-identified, and we have very safe de-identified methods um, to Midrick. Uh, People have talked about individuals saying, I want to give my image. That's very difficult. We want that. And we would encourage you then to go to your institution and say, be a part of Midrick, submit to the cases to Midrick because we do it in bulk. We don't have a mechanism where an individual could just upload theirs. Um, and we don't deal with identified data. We only have de-identified. So, call me or email me. It's easier to get hold of me that way. And I could see maybe we can work out a way for you to get your institution to be a part of Metric that way.
So then
But thank you.
is it assumed that,
Mhm.
yeah, it's a great question. Is it assumed then, like if you are getting imaging done at the University of Chicago, let's say that your, your images would automatically be included in this in Midrick or
No, we should no. We have about 14 sites we work with.
Mhm. Okay.
So we have not announced where those sites are from yet, just for once we're almost at that critical point. I want to thank them publicly and we can't. So I can neither confirm or deny. How's that?
Yeah, yeah.
Um, So, and there's a lot of different images. We started out with lung CT and lung chest radiographs. We then went to brain MRI. Um, Breast, we have a couple of places with huge um, breast imaging data sets that they want to work with us and get it up. So right now we have not publicly released where we get the images, but it
Um,
all goes through an IRB, so it's all
right.
good.
So this is kind of an interesting question because AI, like, with the advent of like ChatGPT, and it's such a hot topic, right, lately. But you seem to be been working on this for quite some time. So when did you first start um, working on computer aided diagnosis and artificial intelligence?
It was back in the mid 1980s. It was a group. It was part of the Rossman Lab, which was headed by Kunio Doi. It included Charlie Metz, Heba McMahon, Bob Schmidt, Gillian Newstead. Besides me, we have Sam Armato and other Bob Nishikawa, Yulei Zhang came along. Uh, that was when we started with the computer aided detection. Um, and that was in pulling out these intuitive features like shape, spiculated, as well as then the new deep learning started coming out. And we have one of the original inventors, Wei Zhang, who came to the lab and implemented that. So you can see it was a lot of people's in the mid 80s. And by the mid 90s, it was being licensed by the university to R2, which went to commercialize it. It keeps getting better.
Mm.
Um, but a lot of the principles of the need for data, how do you safely evaluate? How do you go through FDA? A lot of those basic principles still hold. And now, though, I mean, back then, I was also looking at chest radiographs. It took me 1 hour to digitize the chest radiographs. It took me 4 hours to process it. Now everything is instant, right? The computers now are faster. The storage is bigger. We can do things now that we couldn't do back then because we were limited by the compute.
Mhm. Oh, it's amazing how much this predates, LLMs, large language models that we think of with
Right.
today.
And that reminds me, if you go to midrick.org, we also have a RAD GPT, RAD GPT. We have many tools. I only put one on here. Didn't want to run out of time. That one, if you put in your radiology report, because nowadays uh, with the new laws, people who get a radiology exam must get their report right away, and often they get it before their primary care physician gets it. And then they're reading it, and it's in medical lingo. So this RAD GPT that's on our website, midrick.org, you can find it under resources, and I can easily go to it right now too. Um, you can type in your report, and it will then explain it back to you roughly in about eighth grade language, so
Amazing.
you can understand it. So give it a try. Let me know how it goes.
Oh yeah, I'm gonna try to find that and put it in the chat box if I can get it during this.
Yes,
That's amazing. I would love to.
yes.
Um, Someone asked here, so there was a question about data, asking how safe are the data that you collect?
Mhm. So we collect what from basically we go to hospital and we would do, say, a dump of we started with COVID. This was started with COVID money of chest radiographs or CT and the truth about whether they had COVID or not. How safe it is. Well, it's very safe. You can't re-identify it. I think we have one of the best de-identification methods, and we're constantly improving it. And that includes items that might be burned into the image itself. We have uh, we have the truth files. Well, it's as safe as if we bring in the clinical tests from the hospital, it's as safe as that clinical test. Is a hospital clinical test always right? Probably not. There's errors in everything because we're only human. And so we use clinical data, so it's as safe as clinical data. We also then go on because we're on challenges and all. We look to um, uh, uh, get them these cases annotated. So we may know that, let's say, this image has a cancer tumor, but we want it to be outlined because AI people are interested in segmenting that lesion. So we bring in experts in their field to help us annotate it. So those are also, so that's adds to the safety of the data. You can interpret safe many different ways. I'm not sure. Mhm. Oh, thank you for putting in the chat.
So someone asked, are we hold on, sorry, I just had it up. Okay. Are we there yet with AI to use AI to identify precancerous markers?
Yes. Okay. So I've done work for 30 years on risk of breast cancer, and I didn't put that in because it slipped. I focused on screening and diagnosis. Back in the 90s, we were assessing the risk of a mammogram based on priors, based on normal images. We were comparing it to, back then we had the Gale model, and then we moved to others, and now we have a big enough data set because what you really want for that is a data set, say, of 10 years, the same patients over 10 years, where you can analyze that mammogram from 10 years ago and you will have known if they got breast cancer or not. So we have shown very promising results doing that, but it's been for data sets of a few hundred. To me, that's not enough. But we are at that point, and there's a couple of models that have gone through FDA are clinical, where they look at the normal mammogram and it will assess the risk of getting cancer in 5 years. So we're getting there. Nothing is used without a clinician yet.
Mhm.
I don't think so. So,
And then sort of along those lines, I had gotten a question. I'm going to kind of combine two. One of them was asking about was there uh, you work with radiologists. Did you experience pushback from radiologists who, did not want to use this, or did they all view
mm.
it as a helpful tool for their own work?
Even in the early days in the 1980s and 1990s, of course, there was always that expert radiologist who says, this is great, and it will really help Joe down the street. But okay, you're going to run into that.
Mhm.
But that's okay because it's going to help bring up, and there are tests done. We're using AI, computer-aided detection, computer-aided diagnosis, brought the performance level of those not so good closer to that of the expert. So that's what's important to kind of have everyone perform at the same level, and also bring up the performance level of those performing not as well, and also reduce the variability between the readers. There's a lot of variability between them. So that's important. Um, uh, your question, what was your question?
It was about so getting any pushback from
Oh,
radiologists.
yes, yes, thank you. And then I had one radiologist who, back in the late 90s and early 2000s, people were having their screening mammograms read by a computer clinically. And he would tell me he's never had a patient say to him, Doc, don't put it through the computer. So it was welcomed by the public. Our planes are flown by AI. It was very welcome back then. And it continues to do so. I think what happened, there was a group that started saying AI was going to replace a radiologist maybe about 8 years ago, and that was a big mistake. We've always presented it as an aid, and it's another test result. It's like you get all the blood tests. These are results on images, and you incorporate that in your overall diagnosis. The radiologist, so I'll say, have to say it in every talk, right? The radiologist who does not use AI will be replaced by the radiologist who uses AI. AI is not going to replace the radiologist.
And
It
that
will just help them with give them a bigger toolbox.
Okay, thank you. That answers the related question was do you foresee AI outpacing a radiologist's ability? So
Mhm. And keep in mind that, like in screening, it's like, where's Waldo? You all seen that book? Say you have a 1,000-page Waldo book and he's on 5 or 6 pages only, and there's some red and white buckets, and you have to find them. It's a very tedious task. And the computer could help zoom in on red and white, could even help characterize that this is Waldo or not. But at the end, you have to say, I agree or I don't. So,
Um, there was a question here asking about, do you think that AI could be used to, sort of even the playing field for underserved areas and rural and underserved areas, when it comes to breast screening?
yes, I think so. Because, well, in screening, if you go to the rule out, let's say screening is able to say 20, these 20% or these 30% of your screeners are so normal, they can come back the next year. Now, of course, if the patient doesn't come back the next year, that's a different story. But if you're on a routine screening cycle, so that reduces 30%, right? So that would help in the rural. And AI, if people in the rural area are getting a mammogram, AI is built into the system for detection. And so what I've learned in these low-resourced areas, it's not so much finding cancer because there's mobile mammography units and AI is built right in it. They can find it. The problem occurs when they are diagnosed with cancer and they can't travel the 100 miles to the hospital constantly for care. So it's not so much the screening, but the diagnostic and the treatment.
And then I have a question here, and I think you alluded to it in your presentation, but how might AI be used to assist in developing personalized screening schedules and risk stratification?
With more data,
Mhm.
because we need, and that's why we have Midrick, because some of these mega companies are buying up data, and there's people out there with clever ideas. They need that data, and it's not accessible. So Midrick aims to do that, get more data to make it for everyone to use. And with that, you could see where there's going to be a pattern, just like look at the biology of cancer, where it used to be cancer or not cancer. Then it came to the molecular testing, then it's genomics. As we learn more, the computer is very good at assessing patterns. And so, yes, that is part of the future, in my view, my opinion on it.
Okay, and those are all the questions that I'm seeing in the chat box and that came in to me. So we'll go ahead and end it there. Is there anything that any last last thing that you'd like to say, or like sort of a closing statement on all of this, Dr. Geiger?
No, I want to thank all who have continued to support the research endeavor because that's how we get the next best thing to help in fighting cancer so we can find it earlier and cure it more efficiently,
Thank you so.
effectively.
This was really fantastic. Thank you so much, Dr. Geiger, for joining us today. We really appreciate you sharing your expertise with everyone here.
Well, thank you for the invitation.
Sure.
Bye.
Like I said, feel free to hop off. We're just going to wrap up with everyone else here. Thanks again, Dr.
Okay. Thank
Okay, so thank you to everyone for your thoughtful questions that you submitted to Dr. Geiger. I'm going to go ahead and share my screen and we'll just wrap up here real quick. We're at 12:57. Okay, cool. So the evaluation link is in the chat box. If you'd like to do it on your phone, you can grab it from the QR code there, and I'll give everybody just a minute to do that real quick. Okay, so this was as I mentioned, our first webinar in our series. We have three more next Wednesday, the 22nd from 12 to 1. We have the founder of an organization called My Density Matters talking about the importance of breast density in cancer screening and diagnosis. The Wednesday after that, on the 29th, we have two members of the Lindau Lab talking about the Bionic Breast Project, and they're going to give a research update on that. And then the very next day, on Thursday, we had to squeeze two into 1 week for due to speaker availability. We're going to have Dr. Melinda Lukens join us and talk about menopause and sexual health. That'll be on Thursday, just as of Just to note, we usually have these on Wednesdays. That will be on a Thursday. And all of these are from 12 to 1. And I believe if you're all on here, that means you would have gotten the registration link for all of these. If not, please reach out to me and I can send it to you. As a note, for anyone who's interested in volunteering with the Office of Community Engagement and Cancer Health Equity at UChicago's Cancer Center, you can email me. I think you all have my email address, or you can email our general office at communitycancer@uchicago.edu. We have lots of opportunities for community members and researchers and clinicians and community-based organizations to volunteer in all sorts of capacities. So please reach out to us. And as a reminder for any researchers and community organizations on the call, we do have mini grants, which are $5,000 grants for community organizations to partner with a cancer researcher at our institution to work on a collaborative project. Again, you can reach out to me directly or communitycancer@uchicago.edu. So lastly, we do have raffles for these webinars. Everybody on the Zoom, your name is entered into a name generator and picks three names for raffle winners. We have two $25 Amazon e-gift cards and one $50 Amazon e-gift card. To our raffle winners, they are e-gift cards. They're going to be forwarded to the email that you used to register for this webinar. That will be the only email that I have for you. So our first $25 Amazon e-gift card winner is, and I apologize if I mess up people's names, Kim Einenberg. Einenberg. I'm so sorry about messing up that name, I'm sure. Our second $25 Amazon e-gift card winner is Sam Fulton. Sam Fulton. And our $50 Amazon e-gift card winner is Lois Davis. Lois Davis. So for our Amazon e-gift card winners, you should expect them next week since I will be off. Yeah, I'll be out of the office. So expect them next week. Again, the email address that you used to register for the webinar today. So congratulations to our raffle winners, and thank you all so much again for joining us today. Hope you have a wonderful rest of your afternoon. Take care.